Hello, everybody. Thank you for joining us. Today, I'll be joined by Dr. Anupam Laul. Myself, I'm practicing at Mount Sinai Morningside, which is a hospital in Manhattan, New York. Very heavy disease population, a lot of glaucoma, a lot of diabetics. So we tend to do a lot of imaging in our practice. And Dr. Laul, he's an associate clinical professor at SUNY College of Optometry here in Manhattan as well. Anu, he is also in the glaucoma clinic at the SUNY College of Optometry, so he sees a ton of glaucoma as well. Together, we'll be talking about the practical approach to the glaucoma suspect. First of all, what is a glaucoma suspect? The Academy defines a glaucoma suspect as an individual with clinical findings and/or a constellation of risk factors that indicate an increased likelihood of developing glaucoma. So these risk factors, there's a whole bunch of them. The big ones are going to be increased cupping, cup asymmetry, RNFL defects that you can see clinically, disc hemorrhages, IOP, thin packs, age, visual field defects that are consistent with glaucoma, so that's an important thing to keep in mind. And then OCT, both of the RNFL, optic nerve, and the macula, which are going to be consistent with glaucoma defects. Family history, African descent or Hispanic race, and then things like pseudoexfoliation, pigment dispersion, and myopia. These first few, the cupping, IOP, PACS, age, and visual field, these were really important risk factors in the OATS trial, and this is what they incorporated into the OATS calculator for those of you that use that. So the way I think about our patients is we have a whole bunch of patients which we know definitely do not have glaucoma. So these are patients that are healthy, normal pressure, no significant cupping, no RNFL defects. And then we have a much smaller group of patients who definitely have glaucoma. These are your 0.9 cups with 30 IOP. They have tremendous visual field defects, tremendous OCT defects. So those are easy to really tell. And then we have this sort of overlap of patients where we're not so sure what's going on. So these are your glaucoma suspects, your ocular hypertensive, anomalous discs. And these are the ones that sometimes sort of keep us up at night trying to figure out if we're doing the right thing, whether we treat or we don't treat. And sometimes it's really hard to tell which way to go, and it's important to have a really systematic way of thinking about these. So for those of us who treat and manage and bill for glaucoma patients, this is something that we've seen pretty often. So low-risk glaucoma suspects and high-risk glaucoma suspects, this is really based on sort of Medicare, CMS rules, and this is how we bill things. So anything with 2 or less risk factors is going to be a low risk, and anything 3 or more is a high risk. Now, the important thing is that risk factors only include these things here. So it's not that long list that I was talking about before. And this is a pretty good way when you're talking about just billing for these patients and using the proper ICD-10 code. But, speaking with Anu, even though we're not in the same clinic, we don't see patients together, we're not even in the same building seeing patients, but we've talked in hours and hours about glaucoma and glaucoma suspects. And we actually have a lot in common in how we think about these patients, and our philosophy is very similar. So we'll be going over something called the Epshtein-Laul paradigm, which is nothing official. We haven't published it. It's not peer-reviewed yet, at least. Maybe in a few months it will be. Who knows? And the way we like to think about these patients that come to us and need glaucoma evaluations, or who we deem need a glaucoma evaluation just because we've been the first person that sees them, is we have low-risk patients. So these are patients that have some risks, but their OCT and visual field is unremarkable. So these are patients with physiological cupping, or maybe their pressure is a little bit high. Then we have patients that are medium risk. So these are patients with some risk factors and borderline OCT visual field findings. And then we have high risk or inconclusive glaucoma patients. So these are the patients that have significant risk factors, and maybe they have discordant visual field and OCT findings, or maybe they have something else that's confounding your test results, like high myopia or other comorbidities. So it's actually pretty hard to tell if these patients have glaucoma. And then, of course, we have the patients with definitive glaucoma. Either you have documented progression, or you have corresponding visual field OCT defects on these patients. So the ones that have an inferior notch, inferior RNFL OCT thinning, corresponding GCA thinning, and a visual field defect, those are easy to tell. And then, of course, you have your non-glaucomatous optic neuropathy patients, which a lot of times you might find while you're checking for glaucoma.
I think that's a really good point, Dan. I mean, one of the big things, of course, that I tend to see as patients are referred into me, before I start any patient on eye drops, I mean, the biggest thing that I need to consider is this truly glaucoma or is this something else? The worst thing that you can do is start somebody on glaucoma meds for 10, 20 years, only to find out later that it's not really glaucoma. And it could be something else. So you always have to keep that in the back of your mind as you evaluate your glaucoma patients.
Sometimes we get caught up in trying to answer a question, is this glaucoma or not? But the real question is, does this patient have optic neuropathy or not? And then once you decide, yes, they have an optic neuropathy, then you can figure out, yes, it's glaucoma or it's something else. Unfortunately, I've had way too many patients that have been on glaucoma treatments for years, and then we find out they have something else going on that's a non-progressive condition or needs to be treated some other way. And I'm sure you've had plenty of those patients as well.
Exactly. Yep. Great point.
What do we do with glaucoma suspects? The big thing is you have to get a full workup on them. So for myself, I like to get fundus photos on the day of their dilation. Then I have them come back for OCT, visual fields, pachymetry, gonio, and then of course an IOP check every time I see them. Anu, what do you do? Because I know in the glaucoma clinic, your workflow is probably a little bit different than how it is for me, where I just sort of primary
Yeah,
care
great point. So,
patients.
I do spend a lot of time, A, in our primary care clinic, and then B, in the glaucoma service. When I'm in the glaucoma service, the vast, vast majority of patients that I tend to see are patients that are referred to me either from the primary care clinic or from an outside referring doctor. When it comes to what type of patients that I tend to see, or in terms of numbers, I can tell you that the vast majority of patients that are referred into a clinic, the big reason that they're referred into me is usually large CD ratios. And I think that's the biggest thing for patients to be referred over to me. The second thing that I do see a lot of is just increased eye pressures. So anybody whose eye pressure is over 21 or 22, I get a lot of referrals for that. And then lastly, things like narrow angles. So those are the big referrals that I tend to see. Things like through exfoliation or pigment dispersion or other secondary types of glaucoma are often missed, and particularly those that have small discs with average size CDs or larger than average CD ratios, again, are often missed. Since my patients are referred in from a outside practice, there's usually things like some IOP values. Some outside docs do some testing, so photographs or pachymetry testing. But in my glaucoma workup, the first thing that I tend to do in most patients is I do gonioscopy. Gonioscopy is key. You cannot define glaucoma without gonioscopy. Coding everybody as a primary open-angle glaucoma without doing gonioscopy is just bad news. So gonioscopy on the first visit. The next things that I tend to do on that first visit are usually a baseline visual field and an OCT, an undilated examination, the optic nerve, and then of course, pachymetries and IOPs. And then based on those findings, that's when I decide on when I'm going to have my patient back. And usually my next visit is going to be an IOP reading, likely another visual field, and a dilation with fundus photos.
Yeah, so I think our workflows are a little bit different, but essentially we're getting all the same information where we're trying to get all our data points. We're trying to get it relatively quickly. So we'll go into a slide where we'll sort of talk about times and things like that. But part of our glaucoma workup is OCTs and visual fields. They compare the patient against the average patient. So the Humphrey visual field, the Cirrus OCT, they have these normative databases that will compare a snapshot of your patient to the average patient. Things like fundus photos, OCTs, and visual fields, they also can compare your patient currently to what your patient was in the past. So let's say I take a fundus photo today. That's my baseline for a patient's optic nerve and cup going forward for years. So every year when I look at that patient's dilated exam, or if I'm doing it every 6 months, it lets me compare to what it was in the past. Same thing with OCT and visual fields. Not only are you comparing to a normative database, you're also comparing it for progression. So imaging helps us both with diagnosis and the detection of progression. So using sort of it in a twofold way. And then of course, once you do your glaucoma workup, it's important you have to follow up your patients and repeat your testing as necessary based on the risk. So this is just a little workflow that we have. Assuming this is a patient I've seen for the first time on their initial visit, I'm dilating that patient probably 95% of the time, at least in my practice. I also get an IOP check. If I deem the patient a glaucoma suspect, then I'll also order a fundus photo to have a baseline of the patient's nerve. And then I usually follow up with the patient in about 6 weeks for an OCT, visual field, PACS, gonio, and another IOP check. I usually like to do it within 6 weeks. The reason why is because one, it lets the patient know that there's something I'm concerned about. And also, patients tend not to be lost to follow-up if you do it relatively quickly. So sometimes patients will show up in a week, sometimes in 6 weeks. It depends on the patient, and also sort of depends on my schedule. Everyone's schedule is a little bit different, where you might have availability tomorrow, or you might be booked out for a month or two. So you have to sort of work around that.
When it comes to judging risk, I think that we've all been in a situation like this where I looked at this patient and their eye pressures are maybe high teens. The nerves look a little bit suspicious, but not very suspicious, and they don't have any family history per the patient's history as part of your examination. And then when you see this patient back a few weeks later and you realize after taking an OCT that there's a huge wedge defect. So it is one of these things where it's really tough for you to assess risk really without having the baseline testing. So anytime that I feel like a patient needs that baseline testing, why wait? So I usually get it done just like you do between the first 4 to 8 weeks of my initial visit.
Yeah, that's a good point, because you might have a patient who you think is low risk, and they might have,
Yep.
let's say, 19 pressure, moderate cupping, then they come back and you notice their pressure is much higher. They have 25 pressure. And then
Right.
you
What
know
if their
that they,
packs are, 470?
yeah,
It's one of those things where that 19 now it worries me a little more than it did before. So, without doing the testing, can't really judge. So I think it's worthwhile to get it done early.
yeah, exactly. Once you have them come back for your first follow-up, which is going to be your second total visit, then you sort of stratify them based on risk, like we were talking about. And the patients who are very low risk, these are usually the patients who maybe have 1 or 2 risk factors. If everything looks great, meaning the IOP is still normal tensive, their PACs are average, their visual field and OCT is unremarkable. Sometimes I'll see them back in about 11 months, and that'll be their regular yearly checkup, and I'll repeat the testing. For the medium risk patients, I'll see them back maybe 2 to 4 months. I'll repeat the visual field, get another IOP check. The high risk patients, maybe about 1 to 4 weeks, again, repeat the visual field and get another IOP check. At this point, I might start considering treatment. So especially patients like, let's say, a high myope, where the visual field might have some defects. The OCT, because of the anomalous nerve, might not be so reliable. So it might be hard to follow these patients. I might start on prophylactic treatment if their eye pressure is a little bit elevated, especially if they have a family history of blindness from glaucoma in the family. The patients with definite glaucoma, you could initiate treatment on that second visit. Ideally, I like to have 3 IOP checks for patients, and hopefully you can do maybe some in the morning, some in the afternoon or the evening to try to get some sort of diurnal makeshift curve for these patients. But of course, at some point you want to initiate therapy, whether that's medical therapy or you need an LPI if they're narrow angles, or SLT. The non-glaucomatous patients, of course, you need to do your appropriate evaluation there.
The thing about glaucoma, and I love this chart, is that the beauty of it is that there is no clear-cut, cookie-cutter approach to glaucoma. And I think we all do something very similar to this. But I definitely agree. I think the importance of getting a few more IOP checks before starting treatment is absolutely imperative. And then, getting some of that additional testing done at 1 or 2 visits, really just to solidify your diagnosis and again, ensuring that you're not missing something else. So absolutely, I think this is great. Yeah.
So I think let's go through a few cases and
Sure.
we'll sort of talk back and forth, see what we do. So this is a 51-year-old Black female. She comes in complaining of near blur. After my refraction, she's 20/20 in both eyes, IOPs in the high teens. I dilate her, and I see she has some moderate cupping, maybe about 0.6. And as I do all my glaucoma suspects, I take fundus photo. So I guess the first thing would be looking at the size of the disc.
Yeah.
Do you have a very large disc? Do you have a very small disc? Is it the disc itself vertically elongated, horizontally elongated? You'll see sometimes. Is it tilted? And then, of course, you look at the cup. Does the cup size make sense for that disc size? And then I started sort of branching out. Do I see any disc hemes? Do I see any defects in the RNFL? Peripapillary atrophy is something you might want to look for. I don't put too much worth on it just because I think our OCTs and visual fields have gotten so good now that things like PPA, which you could find in high myopes or just a tilted disc, it's not so useful for me anymore, at least. What about you, Anu?
Yeah, so again, I think you bring up a good point. What I find, at least in myself, as I look at the optic nerve in fundus photographs, I tend to detect pallor a little bit more. So I'm more attuned to looking for pallor. It's quite easy when you have the fundus lens in front of the patient's eye and you look at one eye and you switch over to the other eye. It's sometimes tough to determine if the patient has a little bit of pallor or not. If the patient does have pallor, obviously we're thinking about, neurotype issues. I love the fact that, you look for disc hemes. I think that's very important. I think the ocular hypertension study really tells us that. So it is imperative. And then the other thing is that I find on photographs, looking at the nerve fiber layers to look at areas of dropout, I find it more difficult as you're doing it in clinic, but analyzing the photographs, I do tend to find areas of nerve fiber layer dropout via photographs. So I love taking photographs.
Yeah, I think photographs are great just because you could compare to two eyes.
Yeah.
And you don't have to worry about the patient moving around, they're
Yep.
blinking, you're getting glare. Here you get one photo in each eye and it's there forever. You can look at it for a minute, you can look at it for an hour. So you
Right.
can really analyze it really, really well. So after I get my images, this patient is a glaucoma suspect. So I'm having them come back. I'm gonna have that discussion with the patient. You do have some risk factors for glaucoma. I'd like to have some more information. Let's follow up for some more testing. And of course, I'll always go into the conversation about any family history. So I'm worried about a brother, a sister, a mother, or a father with glaucoma. And a lot of times patients might not know that visit, but they go home and they start asking people. This patient ended up coming back in about 3 weeks. There was no family history of glaucoma. And of course, we checked the pressure again. PACs were average. Gonioscopy was open. I did OCT, both of the nerve and the ganglion cell analysis, which is of the macula. So one thing, especially important to put into the chart, and this is my chief complaint really, 51-year-old Black female presents for doctor-directed glaucoma suspect follow-up. And that will sort of let me know this is specifically a glaucoma visit, and it's also important for billing purposes because it's not a chief complaint that's elicited from the patient. It's something that we ask the patient to come back for. So looking at the OCT, of course, it's important to first look at overall centration, signal strength. But once we figured out that's all great, usually the first thing I look for is probably down here, the quadrants. So the quadrants is just a very easy and quick way to look green versus red versus yellow to see if there's thinning. But even though that's the first thing I might look at, I spend most of my time really looking at the T-SNP curve and the deviation map. So one thing I really love about the Zeiss series is that they have this deviation map where they're checking the RNFL thickness over this 6x6 millimeter cube centered on the nerve. So not only do you get the T-SNP curve thickness, which is just this one peripapillary ring over here, you also get this whole other area. And that's important for me because not only does it tell you if there's thinning, but it tells you how wide that defect is. It tells you the actual area and direction of that thinning, because thinning that's superior nasal is not going to be really consistent with glaucoma compared to something that's superior temporal.
Right.
And it's really nice to just compare the two eyes always.
Mm-hmm. Yeah, you bring up a good point that way. When it comes to glaucoma, glaucoma is a condition that usually affects both eyes. However, the key in glaucoma is the asymmetry. So it is one of these things where, most of us, our hands are about the same size, our ears are about the same size. So we expect our nerves to be about the same size and our nerve fiber bundles to actually look relatively similar between the two eyes. So anytime there is a disparity or discrepancy between the two eyes, it definitely raises red flags. The other thing that you mentioned on the deviation map is that I've had patients where they had maybe the tiniest sliver of dropout that really didn't get picked up on the T-SNP testing circle. So it's slightly outside. So by finding it on the deviation map, I think it's a great way to look for those type of tiny little slivers may not show up on the actual T-SNP curve.
And then we have the ganglion cell analysis, which is a little bit newer, but I've been getting on all my glaucoma patients. I don't use this just in isolation. I always use it in combination with my RNFL OCT because I feel like I'm not going to change my management based on just the ganglion cell analysis. Now, if it matches up with what I see in the nerve and the visual field, that's a different story. But more often than not, it's more complementary for me with the RNFL analysis. So for example, if I have an inferior defect, inferior temporal on the left eye, I'm going to be looking for GCA thinning on the inferior side in the macula as well. I know, how are you using the GCA? I know we've talked about it and you're using it a lot as well in your office.
The RNFL thickness, I mean, that's obviously the first scan that I look at. The first things that I tend to do is I look at the RNFL thickness map. So it gives me sort of a heat map. So, I can easily visually compare the two eyes. Exactly. And then I move on over to my deviation maps. So for me, what I tend to look for is that if there's areas of suspect on my RNFL, does it also correspond on that ganglion cell analysis? So I look for a collaboration between the two because I know that glaucoma itself, you have these arcuate-like type defects or these wedge defects that, subtend the nerve and that macular area. So really what I look for is, does this make sense? Do I see something that collaborates what I'm seeing on the rest of my testing? So I totally agree with you. You really can't look at it in isolation.
So of course, we don't look at this OCT in isolation. We also look at our visual field. So of course, I got a visual field on this patient. And this is the patient's first visual field. And like most patients, it's not perfect. These are real patients. These are not, sort of schematic patients where everything looks perfect. This patient does have some defects in the pattern standard deviation. It is pretty central, so that might be worrisome. In the left eye, there are some central defects as well. It's more so on the temporal side, not the nasal side, so it makes you think what's going on. But, a lot of the new literature coming out, and, I say new, but it's been several years now, we do know that macular defects, both on the OCT and the visual field, do happen in the center in all grades of glaucoma. So it's not just our advanced patients that have a small island of vision left over. It's also our early and moderate patients as well. So it's important to really look at the whole visual field.
For sure. Yeah, I mean, the fact of the matter is, we know from our hill of vision that, our macula is the most sensitive portion of that hill of vision. And that being said, as those nerve fiber bundles subtend towards that macula, by analyzing those central defect points, it could be an early pickup or an early indicator of damage. And it is one of those things where, there's less variability centrally. There's more variability the further you go out. So that being said, if there is something that does get picked up centrally, I think it's worthwhile to explore it.
Yeah, and also that's what affects our patient's quality of life.
Right.
The central visual defects, that's going to be much more prominent in the patient's daily life compared to peripheral defects. So the big thing is, of course, we got to put everything together. So we have 2 IOP measurements for this patient. We have their PACs, gonio, we have their CDs, we have their visual fields, fundus photos, and OCT. So at this point, this is a patient that has some risk factors. So we can say race, we can say moderate cupping, and then maybe we can start thinking maybe there's some defects here on the visual field. So I definitely want to, one thing, follow up with the patient again, check the pressure one more time, but also I want to get another visual field because this is their first visual field, so it is going to be some sort of learning curve. The big thing is because of those macular points, I also do want to get a 10-2. I've started doing 24-2s and 10-2s just to get a better idea of what's going on. Especially if I see one of those 4 central points affected, I'm definitely getting a 10-2. What about you, Anu? Are you incorporating 10-2s into your practice?
Yeah, I actually do them quite a bit. It's one of those things where judging on the patient's risk, unfortunately, there's no clear-cut, time to do 10-2. So judging on the patient's risk, judging at the fact that, do I see changes on that ganglion cell analysis, or do I see little sliver defects on that very temporal end of those nerve fiber bundles, superiorly and inferiorly, that might subtend to that macular area. And then lastly, do I see visual field defects that pop up in the middle of my 24-2? So all of those things play a factor on when I see that patient back to do a 10-2. If I'm looking at a patient saying, well, things are actually looking pretty good, they're relatively low risk, just like your patient is, I think 4 months is great. If I see that this patient has thinning, particularly, superior temporal thinning, which might show up in that inferior nasal macular spot, then I may see that patient back in a month. So, again, there's no clear cookie cutter approach. You really have to look at those risk factors as a whole. Again, if this patient's pressures were, 24 instead of 17, again, I might see that patient back sooner. I do them quite often, and judging when I do them is really based on the patient's risk factors and what I'm seeing. on the initial testing.
So I had the patient come back, and so this is about T plus 5 months. So remember, the patient came back in about 3 weeks, and this is 4 months after that 3-week follow-up. So total, it's about 5 months from your original visit. So I repeated the visual field. We have our initial visual field up here. So the right eye definitely looks a little bit better. The left eye, I guess maybe I'm a little bit happier because now there's not as many central points, but now there's something new happening up here. And like I said, these are real patients, and unfortunately, a lot of times you never get a clean field. I've had patients who've done 10 visual fields over a 6-year period, and it's just, unfortunately, it's never perfect. The other thing was, of course, the 10-2. Actually, the 10-2, like you were talking about, there's less variability, and this patient is actually pretty good at doing 10-2s. So this came out pretty clean. So even though originally we were worried about maybe some central defects, 10-2 shows nothing on it. So I apologize. I know this looks a little cluttered, but unfortunately with our glaucoma patients, we collect a lot of data. So even though it's a cluttered slide, it's all very important for us. So this is just 3 visits worth of data. Once you go for 5, 6, 10 years of monitoring your patients, you collect a lot of data. It becomes very cluttered. So I think things like Glaucoma Workplace with Zeiss Forum, those types of software review systems are very, very helpful. Not only do they have integrated diagnostics where they're pulling in your OCTs of the optic nerve and the macula, they're also pulling in fundus photos and all different types of visual fields. Because I'll tell you, it took me quite a while to put this together, and it doesn't even look that good, So when we have everything together, the OCT looks pretty good to me. A cupping, of course, moderate cupping. We haven't seen any dyschemes on follow-up. I always check my patients with undilated view to see if anything's changing. Though we don't really expect anything to happen within a few weeks usually. And the visual field overall looks pretty good to me. What do you think, Anu?
Yeah, I think you're absolutely right. For the most part, I'm not very concerned. Now, the patient did miss one tiny little portion on that 10-2 that may correspond to that spot on the initial visual field. However, on a case like this, I'm kind of there with you. I probably wouldn't, treat this patient at this point. I think it's worthwhile just to continue to follow. I'll sort of tell the patient that at this point, things are looking quite good. Things are relatively clear, and let's keep a good watch on things. Make sure the patient doesn't get lost to follow-up. But yeah, I'm right there with you. So I agree.
Yeah, so that's what I ended up doing. This patient is still a glaucoma suspect.
Yep.
And I'm following the patient up in 6 months. I'm going to have a
Perfect.
DFE, an OCT. That says just RNFL, but I'm going to do a MAC OCT also. It's just in my mind, RNFL OCT automatically means GCA and nerve.
Yep.
And I'm going to repeat a 24-2. I don't think I'm going to repeat a 10-2 at this point, but this is basically patients coming back for their yearly follow-ups. This is about an 11-month follow-up from their initial visit. So it's good to get the patient back on a sort of almost yearly schedule, but also it's important to repeat your testing. So for this patient, which is a relatively simple glaucoma suspect, I'm going to have 3 24-2s in 1 year, and then we're going to have 2 OCTs that are about a year apart as well. This is another case. So again, the flow sheet was easy. The cases are a little bit more murky, and that's just what life is with these patients, unfortunately. This patient is a 47-year-old white male, presents for his diabetic exam. He has no complaints. He has great vision. His IOP is a little bit high, and of course, I dilate him. First thing we notice is his cups are a little bit larger, maybe about 0.6 in the right eye, a 5.5 in the left eye. And remember, he is diabetic, so he does have some diabetic changes, some mild NPDR. Of course, as you can see, I did take a fundus photo on that first visit, like I do with all my glaucoma suspects. And of course, I have the conversation with him. We need to see you back. We need more testing. So he comes back in about a month, and the family history, he went around and asked his whole family, and he came back and he told me his stepsister has glaucoma. And I'm like, that's great. I'm glad you asked everyone in your family, but that doesn't really do much for us. Not too helpful for me. His pressure, again, a little bit elevated. His PAC's a little bit on the thinner side. His gonio is open. So looking at his OCT, of course, the quadrants is the first thing I look at. All green, white, making it super normal. So it's a little bit thicker. And then the deviation map looks pretty good as well. And we move on to the visual field. Again, visual field, maybe a little bit of defects in the right eye, but overall for a first visual field, pretty clean. These little edge defects probably from the trial lens. I don't think it's too much to worry about. When we look at everything together, especially when you're looking at that quadrant, there is a little bit asymmetry, the 122 versus a 135 superiorly. but it's not really correlating to much on the visual field. There's no really inferior defects that would correlate to. So overall, this patient is still a glaucoma suspect, a little bit of elevated IOP, but I don't see any definite signs of glaucoma. I think at this point, I say the patient's a glaucoma suspect, come back in about 3 months, we'll repeat the visual field and check the IOP again. Any thoughts?
Yeah, no, I think I'm in the same boat, as you are. As I'm looking at the T-SNP curve here, so you can see that superior temporal areas, things are, they overlap quite a bit. And then in the nasal areas, they may not overlap as much. And then they tend to overlap again, in that inferior and temporal portions. So, those areas of discordance between the right eye and the left eye, nasally, we don't get glaucoma on the nasal aspect of the optic nerve. So again, when it comes to risk, I think that you're right. I think this patient's relatively low, but I think it's worthwhile to actually watch this patient. Pressures are sort of at that just above the normal range, larger CD ratios. So I do think it's worthwhile to watch this patient. And the other thing is that it is worthwhile to also get proper baseline testing. Because, if this patient is going to be your patient, he's 47 years old, it's going to be your patient for life, having 2 visual fields and a couple of OCTs, back in 2019 or 2020, and now you're seeing this patient who is now 57, so 10 years from now, it's always good to, have some of that data. And I have an example of that coming up where having that longitudinal data is actually quite helpful. So, yeah, I'm there with you.
Yep, the more data we have, the better. So this patient came back, and this is about 4 months after our initial presentation. And this is actually a 24-2C. So this is a newer Humphrey visual field protocol. I've started using this on all my patients now. I don't do the normal 24-2 anymore. This is fantastic because it's the regular 24-2 protocol, but then it has 10 macular points. So we were talking about how important the macula is in all grades of glaucoma. Well, this is really aligning what we do clinically with what the research is showing. So I've been using this quite a bit. The IOP, again, slightly elevated, but I'm not really seeing too much on the deviation maps on the visual field. Maybe some mild non-specific defects here, and this might be just a little bit of an edge defect. Looking at everything together, again, I don't have any glaring signs of glaucoma here. The good thing is that his pressure, now we have 3 visits, and it's been pretty stable. There's no huge spikes, no huge depression, so that makes me pretty happy that I think we're accurately measuring his IOP at least. Packs are a little bit thinner. He does have moderate cupping, so this is not something we want to forget about. So at this point, still a glaucoma suspect. Want him back in 6 months. We're going to repeat his testing, and the more data we have, of course, the better our decision-making process is going to be. This is another case. This is a younger patient, 32-year-old Hispanic female. She just presents for an ocular wellness exam. Her PCP just sent her in for a regular checkup. No complaints. She has great vision, IOP looks good, but on dilation, she has pretty big cupping. The right disc is a little bit bigger than the left disc, which is really easy to tell on your fundus photos. In real life, unless you're really measuring, it might be a little bit tougher to tell. So of course, she's another glaucoma suspect, and I have her come back for a full workup. So right away, this is a lot different than our other patients. Even though her IOP is great, her PACs are great, gonio is great, we see a whole lot of red and yellow, a whole lot of defects here. So the first thing that I'm picking up is, of course, the quadrants. There's definitely defects here, but then I started looking at the deviation map. Especially in the right eye, these defects tend to be more on the nasal side. In the left eye, I could be convinced that maybe this is from glaucoma. But again, a lot going on the nasal side and less on the temporal side. Look at the GCA, we have 360 diffuse significant loss in both eyes. And right away, this is something strange to me because even in my advanced glaucoma patients, 360 loss like this is pretty unusual. Usually it's still much worse on the temporal side than it is on the nasal side. Whereas here, it's sort of the opposite. It's thinner on this side compared to the temporal side. Mm-hmm.
Yeah, look at that thickness map here. So if you look at that thickness map on the right-hand side, you could see that, yeah, there is some thickness happening on that temporal side, and that nasal side is actually quite thin. You're right, that's very abnormal in terms of glaucoma. Anytime something respects that vertical midline, you should start thinking of other etiologies, because glaucoma usually tends to respect that horizontal midline because that's the pattern of the RNFL.
Yeah, so of course, visual field is a big thing we want to look at.
Yeah.
And the first thing we see is this patient has a bitemporal. So even though this patient had these large cups and we were all going towards glaucoma, we find out very easily from all our testing, this patient definitely does not have glaucoma. Yeah. Now, was it a waste to do all this glaucoma testing? No. This patient might develop glaucoma in the future, and it's good to have a baseline for this patient. But of course, more important, we need to get this patient into the right hands. So because of the bitemporal, of course, the first thing I do is order an MRI of the pituitary for this patient. Unfortunately, this happens more often than I would like, where I'm searching for glaucoma and you find other things going on. Luckily, this patient ended up having a pituitary macroadenoma. She had successful surgery with neurosurgery, and now she's actually doing really great. Her visual field ended up being much better after the surgery as well. And she's still 20/20, maybe 20/20 minus. She's really asymptomatic, which is fantastic.
That's a great outcome. It's really tough, especially on those patients that have significant loss on that ganglion cell analysis. That usually tells you that it's been there for quite some time to get that retrograde degeneration. And it's very variable on the patient's outcomes in terms of will they recover some of that visual field post-surgery.
Yeah, and I think the big thing is, 20/20 is just one little half a degree on your retina. So if she's fixating with the nasal side of her retina, where her sensitivity is still 27/28 and 28/28 in the other eye, she has fantastic vision on that half of her retina. It's just, unfortunately, the other half doesn't have such good vision. Right. So always important to think, not just glaucoma, but think, is it optic neuropathy or not? So sometimes you got to step back on these patients.
This is another example of, just things have to make sense, So when it comes to all of your test findings, because I had a patient like this, very similar, where she had these huge discs, very large discs, and obviously with very large discs comes large cups. And her packs are relatively normal, and her eye pressures were actually in the low teens. And she was sent to me for a glaucoma workup. And sure enough, did a visual field, and the pattern looked very similar to what you have right there. So it is one of those things where, you're right, we tend to see this very often, and this is where everything has to make sense. So the visual field, the OCT, and how, the nerve pressures, all of those things do need to make sense in order for us to make that diagnosis of glaucoma.
It makes me think, should we just have a visual field and OCT on everybody at some point in their lives, So this patient, a little more interesting than our other glaucoma suspects. So this is a 65-year-old black male, comes in complaining of near blur, ends up having great vision with the refraction. IOP is borderline, dilate him, and he has moderate cupping. But the big thing is he has this little disc heme. At this point, I was working with fourth-year students supervising, and unfortunately, the student did miss it, but luckily I caught it without the fundus photo. So we know that on the OATS study, 83% of these disc hemes were missed clinically. And these are glaucoma specialists that knew they were in a research study, so they were really trying really well to examine their patients. So they're missing the huge bulk of their disc hemes without fundus photos. It's like, what hope do us regular docs have,
Again, it's another reason why we really need to continue to take disc photos. I think disc photos are so important.
Yeah, I think because OCT and visual field has gotten so good that fundus photos have sort of fallen out of favor, but I get them on all my glaucoma suspects, or at least I try.
Yeah, it's one of those things where with my glaucoma micro-credential students at the college, one of the first lectures that I gave them really dissected the optic nerve. Because really when it comes to glaucoma, it is a disease of the optic nerve, and you really have to look at the optic nerve. So getting good at analyzing the optic nerve is imperative. The more that you tend to do so, the more likely you are to pick up some of these things like disc hemorrhages and not. Unfortunately, as we're going through and doing our examinations, we've been so ingrained to think about CD ratios that we only look at that center portion of the optic nerve, and we sometimes don't branch out. And sometimes disc seams are right at the edge like that, or sometimes even just slightly outside of the cup or the disc. And if you don't kind of move your eyes out that way, you'll absolutely miss it. So, great pickup.
Thank
I
you.
can see that you're better than students.
Yeah, that's good. I mean, this scheme, you look at it, it's really almost camouflaged with those
Yeah, it's a
blood
tough
vessels
one.
right there. It's really
Sure.
tough to pick up.
Yeah, yeah, that's a really tough one.
So of course, this is a glaucoma suspect, and they're coming back for the full workup. About 4 weeks later, this patient shows up. Pressure 24-21. So remember, the right eye is the one with the disc scheme, so that's the one we're really worried about. Packs, maybe thin average, but nothing too thin. Gonio was open. And again, first thing I look at is the quadrants. Everything looks fantastic in terms of colors, but look at that huge asymmetry. And the asymmetry, 114 in the right eye versus 156 in the left eye, that really corresponds really well with the disc scheme that we saw and the bigger cup in the right eye. And that, of course, also corresponds with our deviation map, with our T-SNP asymmetry, and our average RNFL thickness asymmetry. So this is what we were talking about before, where even though the quadrant is green, you can clearly see that RNFL defect, even though you might not see an RNFL defect clinically, but that's right
Yeah.
where that disc scheme is. So this is why I love the Zeiss deviation map, that without that really sort of red and yellow highlighted, it might be a little bit tough for you to tell, unless you're really looking at these asymmetries between the two eyes.
Yeah, it's kind of interesting. Now, this is where we differ a little because I don't spend a lot of time looking at the quadrants. The deviation map is the heat map deviation map, and then looking at the symmetry of the T-SNP curve, because you can clearly see as you circled it there, that inferior section, there's a big difference between the right and the left eye. That solid line, which is that right eye, there's a huge dip or deficit, which requires investigation. So yeah, great pickup.
And of course, we get our visual field. And the visual field corresponds pretty well. So you have that superior nasal step correlating with our thinning on the RNFL. That's really picked up pretty well the deviation map and our T-SNP curve. And of course, with that disc scheme we saw. So with this patient, I think we can say this is definite glaucoma. We have correlating data there. Ideally, I always like to get 3 IOP checks. So I actually had this patient come back in about 1 to 3 weeks to get another IOP check, but I told them, look, you're coming back, but you're starting treatment no matter what. So he was already set up for it. And I think his IOP was about the same. This sort of lets me know what his Tmax is and how to develop his target IOP.
And I think you actually bring up a good point. Throwing this all at a patient at once can be sometimes overwhelming. So what I do like to do is I like to show the patients the data, look at the findings here that I have, talk to them about their pressures and their visual fields. And then I say, really our next steps is some sort of intervention, whether it be eye drops or whether it be laser, some sort of intervention. And, I say, why don't we get one more eye pressure check, and it lets them ruminate a little bit, it lets them think about, their condition a little bit, so that when they do come back in, they're already expecting some sort of treatment, whether it be drops or an SLT. So, we're at a point where the patient has really come to terms with it. So sometimes it can be very overwhelming, all of this at one single visit. And I like the fact that you kind of split this up, because that's exactly what I do.
Yeah, that's a good point. From the patient's point, it's sort of the psychological aspect of it. It is a lot of information for them. And this is, again, a lifelong disease. This guy's relatively young, 65 years old.
Sure.
So let's say he has 20, 30, 40 years of treatment ahead of him.
The other thing to consider is that, when you hear about things like glaucoma, or if you Google things like glaucoma, it is a blinding condition, and people automatically, think that they're going to go blind. So, I think that, after you make the diagnosis, I do spend a lot of time talking to my patients saying, hey, you know what? This condition is treatable. We can treat this, and we can make sure we can do our best to ensure that you have good, functional, useful vision for the rest of your life. I'm definitely going to work with you. You need to work with me. So when we do start putting you on some eye drops or medications, I do need you to come back in for your follow-ups. I do need you to take your medications as prescribed, and together, we can make sure that we maintain your vision. And I think that's that team approach. So me and the patients, that team approach tends to increase compliance, tends to increase patients coming back and being more fruitful with their medications. So
yeah, that's a great point. So once a patient has glaucoma, we have to sort of grade it. And the Academy and American Glaucoma Society and sort of ICD-10 way of grading it is going to be here on your left side, where they have mild, moderate, advanced, It's a little bit different than what I think we do clinically. I use the Hodat-Parrish-Anderson criteria a lot, where it's also early, moderate, and severe, but this is based on more on the mean deviation of your visual field and the sensitivity of specific areas on the visual field. The criteria on the left side, this makes more sense, of course, for billing, that's what you got to do. But in terms of visual function, so mild or early patients, they have no visual field defects. Moderate patients have defects only in one hemifield, and then advanced, of course, is anything worse than that. So it does make sense in one way, but then a lot of our landmark studies, they didn't really use something close to that. They used something more similar to maybe the Hodat-Parrish-Anderson criteria, or there's other glaucoma severity score scales out there.
Yeah, absolutely. So, I think it's one of those things that, from an academic standpoint, this is what we teach our students. We talk about the Hodat-Parrish-Anderson grading systems. And I think it is one of the things that when it comes to classifying glaucoma, from an academic standpoint, that's really what our students know, really what our students learn. But when they do get to me in their 4th year of clinic and they're in my glaucoma service, I usually sort of show them the Academy of Ophthalmology and the AGS grading scale, because as you can see, it actually does talk about the ICD-10 codes. And for most students, and I think for most practitioners, it's an easier approach, because it's just a couple of bullet points. So for mild, you have the optic nerve abnormalities, but with no functional vision loss on a visual field test. For the moderate, you have the optic nerve abnormalities, but you also have visual field defects in one, hemifield that's not within that central 5 degrees of fixation. And then the severe is within central 5 degrees of fixation or loss in both hemifields. So from a conceptual standpoint, I think for a practicing clinician, that might be an easier grading system. But when we do all our studies and from an academic standpoint, the Hodat-Parrish-Anderson is probably the way to go. That little sheet that you have, I print that off and I keep it in the clinic, because as you can see on the bottom, it also has the risk factors for open-angle glaucoma suspect. And just like you mentioned it, less than 2, low risk, greater than or equal to 3, high risk. So again, it's a good visual on your busy clinic.
So what do we follow up our glaucoma patients? And that really depends, are they stable and what severity of disease they have. But even though we have these guidelines from the AOA, the big thing to know is that they need a DFE, they need an OCT, they need a visual field, they need gonioscopy at least once a year. I think that's for all our glaucoma patients, and everything else there, you really got to do on a case-by-case basis. And then, of course, once you have a glaucoma diagnosis, or if you have a glaucoma suspect and you're monitoring them for long periods of time, you're checking for progression. So, of course, there's different types of progression. You can have a deepening or worsening of a defect, whether it's on OCT or visual field. You can have a widening of that defect, or you just have a new defect in a different area or in another eye. And then you need to always consider age-related changes, because as we get older, we do lose some axons, we do lose sensitivity on our visual field. And that's always very, very important when we're looking at progression, we're looking just at raw data ourselves. So you got to remember, what is normal change? And then we need to consider variability that the instruments have when you take measurements. The glaucoma disease has variability. And of course, anyone that's done more than one visual field on a patient knows the significant variability of our perimetry testing in patients. Luckily, Zeiss created this guided progression analysis, which is available on both the Zeiss Series OCT and on the Humphrey perimeter, which it evaluates data in the context of variability. So it provides objective interpretation of progression. Because if you're looking at just at raw data, you might have a hard time figuring out, is this true progression or it's just variability based on the instrument or the patient. This Zeiss GPA data, it helps guide our management. It helps us answer questions like, is a patient's glaucoma worsening? If it is worsening, how quickly? Is it a fast progressor or a slow progressor? So it's important that if you have something like a fast progressor where you're losing 2 decibels of sensitivity on your visual field per year, in 10 years, you could go from pre-parametric glaucoma to advanced loss with significant effects on your vision quality. Whereas someone who's progressing very slowly, especially if they're a 90-year-old, 95-year-old patient with a shorter life expectancy, you might not need to intervene. It's going to help us sort of figure out, do we need to change our treatment? Because this GPA analysis can also extrapolate data. It sort of gives you this nice slope, which I think we have a few slides of that coming up. And it'll help you predict what the visual field parameters will be in the future.
Awesome, Dan. Thank you so much. So you actually bring up a really good point. Progression, I think that's the real value of the OCT, because we know that glaucoma is a progressive condition. So I think the big benefit is looking at change over time. So the examples that you showed were done in a relatively short period of time. We're looking at this event analysis. So let's have longitudinal analysis. Let's look to see if you have a patient who's been under your care for a long period of time. And I can say this is a great case that I have where the true value of that progression analysis really shines through. So, I started at SUNY in 2016, and we had a patient that I've acquired through the glaucoma service who's been a patient in the glaucoma service for a number of years. So to give you an idea of this patient, she's a 63-year-old Hispanic female back in 2016, and she does have a history of narrow angles. As you can see, she underwent successful LPI procedures, 2006 in the right eye and in 2007 here in the left. Prior to the LPI, this patient's eye pressures were 27 in the right, 26 in the left. As you would expect, a patient who does have narrow angles, this patient is hyperopic. So most of our narrow angle patients are hyperopic, but not severely. Her examination, setup examination are as follows. And as you can see, moderate anterior chamber, patent LPIs, 3 o'clock on the right-hand side, 2 o'clock here on the left. Very mild early cataracts. And as you saw from the patient's visual acuity, this patient is 20/20. So she's just coming on in for her routine follow-up. We know that this patient actually does have these larger cup to disc ratios. And these are her fundus photographs taken in our primary care clinic. As you look at these fundus photographs, as you can see, this patient's vertical cup to disc ratio is in the ballpark of around 6.5, 7. Looking at the rim tissue, they look relatively symmetrical, maybe a little bit thinner inferiorly as opposed to superiorly, but for the most part, the rim tissue looks pretty good. I don't see any obvious hemorrhages or nerve fiber layer dropout, but of course, this patient has been followed in our clinic for a while. She does have a history of narrow angles with that higher eye pressure, but as we've been seeing, her pressures have been pretty good. Pachymetries are just slightly lower than average. And since that LPI procedure, her pressures have been, or they hovered around anywhere from 19 to 21. There's no evidence of PAS or chronic angle closure, in this particular case. But as we mentioned before, having data is quite helpful. So this is her OCT taken in 2016. So as I mentioned before, in terms of the way I look at that OCT is I look at the thickness maps. And looking at the thickness maps here, it gives you an idea of, are there particular areas that are slightly thinner compared to the other? And this is an image of the right eye. This is an image of the left. And I can kind of see that, maybe the left eye is not as robust as compared to the right. The average thicknesses are 97 in the right, 84 in the left, with a pretty good symmetry. When it comes to flagging on that deviation map, in the right eye, nothing is really flagged for the most part. The left eye, still looking pretty good. Could this be a possible flag? I think it is something to keep a good watch on. As I mentioned before, and I think as you brought up the good point, is that, this actually dips outside of that, sample circle. So it may not show up on that T-SNP curve, but looking at this total deviation map, I think it's worthwhile to kind of look outside of the sample circle because it gives you a lot of insight. The other things that I tend to look at is I do look at that circular tomogram because this is the circular tomogram that makes that T-SNP curve. And if there's areas of traction or if there's an impending PVD, that lets you know that this T-SNP curve data might not be as accurate and you may want to recheck that. Since you mentioned the quadrants, this patient's quadrants and clock hours actually look quite good. When I look at that T-SNP curve, it looks like to me that that left eye in some areas are slightly thin as compared to the right. Obviously, we also do a ganglion cell analysis. This is the ganglion cell on this patient. And again, for the most part, the sectors look quite good. I think it's worthwhile to look at areas where you would expect glaucomatous damage. But again, at this point, The patient already had her LPIs, pressures of 21. For the most part, the OCTs are looking pretty good at this visit in 2016, so I think it's worthwhile for us to carry on and follow her. I was not at a stage where I figured that this would be worthwhile to start a patient on medications at this point, because for the most part, things were looking relatively robust. Obviously, we take visual fields as well. Luckily, she's a good visual field test taker, and as you can see, very clear visual fields. I don't think anybody would look at this visual field and say, hey, this patient has glaucoma. This visual field was actually taken in early 2017. So when I saw her, it was late 2016, and we had her back in a month to get that visual field taken just due to logistics issues. So let's go ahead and fast forward to 2019. So I saw her actually late 2019. So as we look at this visual field, again, for the most part, things are looking relatively good. I really don't see much of a difference. Is there a slight decrease in the mean deviation as compared to that previous visual field? Sure, but she went from 63 to now 66. She does have the earliest cataracts. Again, nothing on this visual field screams out to me that this patient has glaucoma. Let's go ahead and look at that OCT. So this is the OCT that was taken in 2019, so late 2019. When it comes to the average thicknesses, I'm looking at this 89 in the right-hand side, 85 in the left. And you can see that maybe the symmetry has changed slightly as compared to previous. But again, I look at these heat maps, those thickness maps, and I'm looking to myself, has anything changed? Again, as I look for glaucoma, I'm looking at these superior and inferior temporal wedges to see if anything shows up. And as you can see here, it looks like there might be a little wedge which was picked up right here on that deviation map. That's why I think the deviation map is so important. When you kind of look at this area on that T-SNP curve, yeah, it actually shows up here as well. So that right-hand side, it's actually looking a little thinner as compared to what it did previously. But nothing has showed up on those quadrants. I think we mentioned that if there's a really small defect, it might get missed in a quadrant. So it is so imperative to actually look at that deviation map and look at that T-SNP curve as well. You don't want to look at anything in isolation. As we look at that ganglion cell analysis, again, for the most part, it looks pretty good. You can see that the sectors are relatively normal, so I think we're in good shape there. Has this area gotten worse? Yeah, you know what? Maybe it has. Does it correspond to this area? Quite possibly. This area over here on the left-hand side, that might have gotten worse, but I don't think it changed much. I think it might have changed just a little bit. But again, we don't look at things in isolation, right? So as I always mention, you want to compare and contrast. Why bother taking an old visual field or an old OCT if you're not going to look at it? You're not going to compare it to the OCT in the visual field that you have now. So of course, that's exactly what we did. So on your screen here, what you see is that on that left-hand side, that's the 2019 data. On that right-hand side, that's the 2016. And sure enough, you can actually see that difference, right? So things have absolutely changed. The deviation map did pick up that difference between 2016 and 2019. So in that 3-year period, there is a little bit of a difference. And absolutely, that picks it up right there. Why don't we go ahead and have a look at that ganglion cell analysis as well? So the same idea, 2019 on your left-hand side, 2016 on your right. You can see that nerve, the ganglion cell bundle, that macular bundle looks a little more robust back in 2016. It's a little bit thinner now as opposed to the 2016 data. And absolutely, this area has increased. So that being said, it is one of those things where, things are starting to match up. I'm beginning to think that, is this patient progressing? Does this patient have glaucoma? Is 21 not a good eye pressure for this patient? Do I need to intervene? As Dr. Epshtein mentioned, looking at that progression analysis, looking at that GPA, that's really the bread and butter of glaucoma. I think that that's really the most worthwhile example. So this is a static printout that you can print out on your OCT. And as you can see, we've been following this patient since 2010. So all the way from 2010 to 2019. Again, I'm going to start at the top and we're going to kind of move through it. So the baseline testing, so that was the first test here done in 2010. This is the one here done in 2011. You can actually even see a difference between the first two baseline tests. That, it's not as robust in 2011 as compared to what it was in 2010. And as you move along here, particularly that inferior area, we do tend to see that, hey, you know what? I think we're getting a worsening of an inferior wedge defect. Another way to look at this data is by that deviation map, and you can see that, hey, in this particular spot, we are getting a worsening of that inferior thickness. And I think it's worthwhile to note that in terms of probable loss, the OCT will tell you in yellow that this patient is having probable loss. So you want to watch that area a little more closely. Once you start getting into the reds, that's where we start getting that likely loss. So it's telling you here that, hey, things are changing, and it's a statistically significant change. So sure enough, when you look at the parameters, the actual raw data itself, you're right, that quadrant has changed. So Dan, as you look at those quadrants, this quadrant has changed. Inferiorly, we started at about a 138 microns. We're all the way now down to about 102, and that's a statistically significant difference. The average thickness has also changed as well. So from 101 all the way down to 89. So that is a statistical significance. So there is progression in this case, even though the visual fields actually looked pretty normal in 2019 and pretty normal in previous. Let's move over to the other eye. And similarly, we can see that both inferiorly and superiorly, we are noticing changes. We're noticing thinning of that superior and inferior nerve fiber bundles, which are flagged on that deviation map. So although when I was looking, comparing the 2016 OCT to the 2019 OCT, I didn't really notice a change on the left-hand side, having this longitudinal data over time has really showed me that there is change. And not only inferiorly, but superiorly as well. There is a statistically significant in both quadrants, the inferior and superior quadrants, which is leading us for a average thickness change. So if you can imagine, I was more concerned early on in 2016 of the left eye because the left eye looked a little thinner to me as compared to the right eye. In this case, that right eye has definitely progressed, but we can't really forget about this left eye because I definitely see progression there. The visual fields, luckily, on this patient has remained relatively stable, and this is an example of the GPA analysis of the visual fields. It's taking that visual field index, the VFI value, and looking at change over time. And this person's slopes are actually pretty good. I mean, it's pretty linear. We're not having that downward slope. We're not having that negative slope. It's actually looking pretty linear. So luckily for this patient, we're not seeing that significant loss in terms of visual function. When you look at this data down here, as you may recall, what this data is telling you is that if there's a greater than 5% deviation as compared to previous, it will show you as a triangle. If there's a greater than 5% deviation on 2 consecutive visual fields, you'll have that half colored in triangle. And if there is a greater than 5% deviation on 3 consecutive visual fields, you'll see that full colored in triangle. So, that's the key when you're reading this type of analysis. One thing that we have at the college that I tend to use quite often is form. And this is just another way to digest that data. So on a single screen, I have every single thing that I just showed you. So this is an example of the right eye. So again, looking at that visual field index, I can see that slope, and in this case, we're really not seeing much of a change. This is giving me both the visual field index, but also the mean deviation. And I can change this to look at the superior half or the inferior half. In this case, I'm looking at both, but you can dissect that data out should you choose to do so. The other thing here is that, as you can see, that average RNFL thickness has been changing over time. So taking this patient all the way back to 2010, you can see that this first little spot here was a likely decrease, right? So a likely progression. And as we move on, these spots are in red, telling us that this is probable progression. This is progression that is, that is happening. The other thing that's kind of nice is that you can actually look at those T-SNP curves. You can actually click on here to give you a progression analysis of the T-SNP curves or a deviation. Now, once you have a lot of data, the deviation map is really not that helpful because the deviation map is just showing you their data as compared to the normative database. But when you have numerous OCTs, you want to compare your patient to your own patient. So you want to compare them to themselves. So the progression analysis is actually very, very useful. So I use this all the time. And again, you can actually split this up looking at superiorly quadrant only or inferior quadrant only, depending on how you like to consume the data. One thing that you may have noticed is that the layout on this curve is an Epshtein curve. So we actually change things around. So the T-snit curve is what you're most used to looking at. But we know from a lot of our most recent studies in the past 10 years that glaucoma tends to affect, that superior, inferior, and in the temporal region, not so much the nasal region. So why not align that curve so that that superior, temporal, and inferior regions are smack dab in the center of your screen, so you're looking right in that middle to see where that data lies. And then lastly, this will give you all of the visual fields and all of the thickness analysis over time. If you click on this button here on that top, this will change it to the deviation map instead. So instead, you'll see, instead of the grayscales, you'll see those little triangles on where a patient is losing data. And instead of looking at a heat map, you're going to see a deviation map down here. So again, depends on how you want to consume that data. So looking here at that right eye, we can obviously see that there is progression pretty close to about 2 microns per year. So it is a significant change. And obviously, as we compare the baseline to the most recent, so the most recent is the current, which is the blue line, we can absolutely see that inferiorly things have changed significantly. As we move on over to the other eye, so this is the left-hand side, again, our visual field is actually pretty stable. In terms of the analysis here, the progression rate is actually pretty close to 0. So the good news here is, things haven't decreased significantly on that visual field. However, we are seeing an average thickness of 1.6 microns per year. So there is a significant decrease since 2010. And again, you can consume that data how you like. So really what I want to show you now is this patient's IOPs. So the fact of the matter is that since this patient had that LPI, the patient's pressures went down from 27, 28, all the way down to around 21, 22, maybe 19 here and there. And really what this lesson that I have on this particular case is that a lot of us, when we see our patients and we have patients who have narrow angles, we have the LPIs done, we have OCTs that look pretty good, things are in the green, you don't want to stop following these patients, because I think this is an example of a patient where, having those high eye pressures back in, the early 2000s might have elicited some of this apoptotic mechanism in glaucoma that left this person susceptible that a pressure of 21 is not acceptable for this patient. We had to bring those pressures down. So in this case, we did start this patient on medications. My target pressure for this patient is 15 or below. And you can see in most cases, she ended up 15 or below. A couple of times she kind of fell off here, and it might have been that she didn't take her drops for a couple of days, or she ran out of drops. But, I think a big lesson for me in this particular case was the fact that, having that longitudinal data really solidified that this patient is indeed worsening. And at this point, I think it's worthwhile to enter.
I think that's a lot of great points you bring up. Looking at our patients in sort of a snapshot view is great for our first initial steps of how to manage these patients. But going forward, we're collecting so much data on them that you really got to look at everything. And just like you showed, sometimes us evaluating the patient's OCTs, just eyeballing everything, isn't good enough, that we really need some sort of statistical analysis. That's where these instruments, especially software like Size4 the Glaucoma Workplace, really helps us out quite a bit. And the big thing is you're not making those huge slides like I did where you have a million things on it. It looks terrible there. It's really nice and organized for you. And it's really good. You just change your baselines really quickly as well. So for example, you could change the baselines after the LPI, or if the patient had cataract surgery or a glaucoma procedure, you could change that. Your new baseline is after the procedure, because of course, if you're comparing the patient to the patient before glaucoma surgery, you're definitely going to have some sort of progression. But afterwards, hopefully things end up being pretty stable.
Exactly. So in this particular patient, as you can see, that we started medications around 2017. So you're absolutely right. We can actually re-baseline this patient. And in Size4, I kind of cut off that top area, but there's a button that you can click on adding drops. And you can put the date on when you started the eye drop, and that would actually tell you where the drops were, and then you can reassess this area. So since starting the drops, have things been pretty stable? So this allows me to check that since I started this patient on eye drops, has the patient progressed? So that's a very, very good point. Great. So what I'm going to do now is I'm going to quickly jump into an early glaucoma case. Again, another example of a patient who I've actually just seen very recently. So being at the college, I do tend to get a lot of second opinions, right? There are patients who are diagnosed with glaucoma, and before they start on medication or when they are started on medication, sometimes they want a second opinion. And this is actually a very recent patient that I saw. So a 70-year-old Hispanic female. She presented for a second opinion because she was told that she had glaucoma 2 years ago and was started on latanoprost. She has no family history of glaucoma, and overall, she's in pretty good health. She's not taking any medication. She's not allergic to anything. In terms of her case data, she's a mild hyperope, but her vision is quite good. Packs are relatively average, and her eye pressures were average as well. Looking at gonioscopy, open to trabecular meshwork, flat approach, no pigment, no PAS, so nothing that is overly concerning. But as Dr. Epshtein mentioned, you definitely got to take some testing, right? So this is our visual field test that we've done on her. And as you can see, for the most part, things are relatively good. For a first visual field with us, in terms of the indices here, in terms of how well this patient did, for the most part, I think she did a pretty good job. And I can kind of tell that this patient has taken a visual field in the past because most of my first-time visual field patients, we do tend to get a lot of fixation losses, a lot of false positives and such. So, for the most part, things are looking pretty good. She missed a couple of points here and here, which likely caused us to have this borderline. I think this was the edge of the trial lens. So if that point wasn't there, I think she would probably still be within normal limits in both eyes. So let's go ahead and analyze this, OCT. So again, as I mentioned before, I really like to look at these heat maps. I think they're very helpful. Overall, this patient's average thicknesses are pretty good. 88 microns on the right-hand side, 79 microns on the left, and very good symmetry between the two eyes. She does have these large cup to disc ratios. And as you can see here, that as I look at it, as I eyeball it, inferiorly, things might look a little bit thin as compared to the superior rim. And that kind of leads my eyes on where I need to look. Although the rest of the metrics in terms of the quadrants, for the most part, look pretty good, and the clock hour is only one little spot that was flagged, my student came to me and said, hey, this OCT looks good. I did a ganglion cell analysis. I think things are looking good here. It's quite robust. And I would agree that things are looking very robust. But like I said, looking at the thickness map, looking at the deviation map, there are certain areas. There's a tiny little sliver right here on that very bottom little spot here that's really concerning to me. And as I look over on the other eye, I'm seeing something similar. So a little tiny, tiny sliver that might be something that I need to pay a little closer attention to. As I move over to the ganglion cell analysis, I can actually see that, hey, you know what? There might be this little windshield wiper effect, even though we do have a very robust ganglion cell complex. So you can see the numbers are looking pretty good. But do we have a very early ganglion cell defect in both eyes, which do correspond to this inferior thinning noted on that OCT? So again, this is the first time that I saw this patient. Another way to consume the data, I think one good printout that we can look at is this combined structure function printout. So this gives you that data all on one page. So even if you don't have Forum, if you have your OCT, you can print off in a visual field. You can print off something like this that gives you a combined structure function analysis if your visual field and OCT are connected. Again, it gives you everything on one page, which I think is very helpful. One thing that I do want you to note as well is that I did change this again to that Epshtein curve. So I'm looking at these particular areas. This middle spot is a spot that I'm looking at. And sure enough, you see this absolute dip. Right, so you see this dip right over here, which corresponds to this inferior area. So as I look at this patient, like I said, my student was like, oh, I don't think she has glaucoma. I'm fine to see her again in 6 months. And when I pointed this out to my student, I said, hey, you know what? Let's actually look at this in a little more detail. So as I look at this data, I think that this patient does have some very early glaucoma. My next steps on this patient is to repeat that visual field. Although we tend to spend a lot of time on that pattern deviation, If the patient's media is completely clear, your total deviation might give you a few hints. And like I said, based on where this defect is, I think it's worthwhile for us to also do a 10-2. As we know that these inferior temporal spots tend to correlate to what Don Hood likes to call this macular vulnerability zone, where we do tend to see superior paracentral defects on the 10-2. So in this case, I think it's worthwhile to monitor this patient a little more closely. But again, another great example of a early referred patient that I've seen. My last example that I'm going to show you is a moderate glaucoma patient, but he presented in a very similar way. He was referred in for a glaucoma eval from an outside optometrist. No family history of glaucoma, 54-year-old Asian male, and overall, again, very healthy as well. One thing to note is that he is a very high myope, so about a -6 in both eyes, but he does have thick packs and his eye pressures are really not that bad. So 19 and 20 on someone who has a pack imagery reading of 588 and 591, you feel okay about that, right? But again, I think it's worthwhile to delve into that data in a lot more detail. So when you see a patient like this in your primary care clinic, like you said, thicker packs, relatively normal pressures, you might think that this patient, we can kind of leave this off for a little bit. We can see him back in 6 months. No, I think it's worthwhile for us to get that testing done. I want to show you his photographs. And, this is really, really tough. When you have patients that are really high myopes and you have this malinserted nerve, and this patient also has a rotated nerve as well, it's really tough for us to get an idea of what this patient's CD ratio is. So as I look at this patient, that's a tough call on what the CD ratio is, right? Where does the rim end? Does the rim end here or does the rim end out here? Is this just a scleral ring and the actual papillary ring is this one here? That's what I'm thinking. So this patient's CD ratio is still quite high. I would guess that this patient's CD ratio is probably in the 8.5 range, or close to 9. Inferiorly, I don't see much of a rim there at all. Is this related to the patient's glaucoma, or is this the fact that this patient's very high myope and we have this big tilt to the patient's optic nerve? Is this area peripapillary atrophy, or is this just a choroidal crescent, again, due to this patient's high myopia? Looking at the other eye, it looks very similar. Taking photographs in a case like this, it allows me to dissect where the rim is in more detail. I find myself, again, looking at a patient with my 78 diopter lens or a 60 diopter lens, trying to judging on where the edge of that rim is, taking a photograph and spending the time to dissect it afterwards. I think it's actually very helpful. But let's look at that OCT. So as we look at this OCT, as you can see, things are definitely thin. So thinner as compared to the normative database for a relatively young guy. Not a lot of symmetry. However, this patient does have these very malinserted optic nerves, and you can see that there is a rotation as well. But inferiorly, there's no doubt that things are thin. I mean, there's almost no rim inferiorly on that right-hand side, and a pretty good notch on that left-hand side as well. Superiorly, again, significant defects that do tend to match with this windshield wiper type appearance on that ganglion cell analysis. So again, when I look at this, I'm taking all this data combined. Does this make sense? Does a thinning across here correlate to a windshield wiper defect on that ganglion cell analysis? Does this look like glaucoma? Is it respecting that horizontal midline? In this case, I think it is. And absolutely, you got to do that visual field. So here again is that structure function single exam printout. It's a great printout where you have all that data in one. And sure enough, you do have a superior arcuate defect that corresponds to this inferior deficit and that ganglion cell wipeout. So in this case, we absolutely see what I feel is glaucoma. As you look at that other eye, though, I want to bring up the point is that I don't see a lot of defects that correspond. We just see a few spots here. So one might think that, hey, this patient's doing pretty good on that left-hand side. But because this patient has these defects here centrally, and Dr. Epshtein mentioned that earlier, I think it is worthwhile to investigate that. So Dr. Epshtein, I know you like to take those 10-2s, so can you guess what I did next? 10-2, right? So absolutely. So looking at this, right? Looking at this patient's 10-2s, obviously we see that defect on that right-hand side. So you can see that makes sense with that superior arcuate defect. I'm actually picking up a defect that matches up to that nerve fiber bundle on that left-hand side as well. And because it's so close to fixation, this is going to bother this patient if this progresses to a significant amount. So I think it's worthwhile that even though this patient has thicker packs, his pressures are 19 and 21, again, we had this whole discussion with this patient that, yeah, I really do see glaucoma, and I think it is worthwhile to treat. So looking at this data in different ways, using your 10-2, using your structure function single exam, using your guided progression analysis, and using that forum data, I really think it's the way to go as you monitor your glaucoma patients. Any thoughts, Dr. Epshtein?
You did great. You took a patient who maybe 20, 30 years ago, we would have no idea what's going on with the patient. And you really dissected it down with all the data points that we have available. And I think it just goes to show you how important measuring structure and function is in our patients. To be honest, it makes things that seem impossible much, much easier.
So this is a glaucoma suspect that was sent to me from the primary care clinic. She's a 51-year-old Hispanic female. This patient has been told in the past that she has high eye pressures. She grew up in Mexico and she splits her time between the US and Mexico. And she recently had a glaucoma evaluation 3 years ago in the US and was told everything was normal at that time, just as this patient has higher eye pressures. Currently, this patient is taking Tobradex for some eyelid irritation. She got it over the counter in Mexico. She was having some irritation and one of her friends says, "Hey, I'm taking Tobradex for my eye infection and it worked out great." So she moseyed on over to the pharmacy in Mexico and picked up some Tobradex. And in Mexico, as in other places in the world, you don't need prescriptions for medications that you would need prescriptions for here in the US. She's been using it 4 times a day for the past 6 months. And now she presented to us in our primary care clinic, right? No family history of glaucoma as far as she knows. And she's not taking any other systemic medications, no injuries or surgeries. Her VAs are quite good, a very slight hyperope. She does have some thicker packs, 588, 572. Her eye pressures at our visit was 32 and 31, right? Her ciliary body was seen on gonio, flat iris approach, no PAS. So yeah, her eye pressures are a little bit high. So let's have a look at her optic nerves. So her optic nerves, for the most part, look pretty good. I would say that she does have some cupping for sure. I'll probably call that about a 6:5 CD ratio. Looking at that rim tissue, inferiorly, things are actually looking pretty good to me. Superiorly, yeah, not bad at all. Let's go ahead and have a quick look at the other eye. I'll probably call this about a 0.6. Again, the rim tissue superiorly looks pretty good. Inferiorly looks pretty good as well. I don't see any signs of obvious thinning, no hemorrhages, and the nerve fiber reflection actually looks pretty good here as well. But of course, we always take our OCTs. I think it's worthwhile to go ahead and do so. And as we look at that OCT, I think this is an example of a very normal looking OCT. The average thicknesses are 104 in the right, 102 in the left. And when you look at the thickness maps, they almost mirror each other. This patient's symmetry is spectacular, 93. The disc area is a little large, so she does have a large cup, a large disc, which you would expect of this patient to have a large cup as well. Nothing really flags out much in our superior, inferior, and temporal areas on our deviation map. So looking at it here for the most part, like I said, I think this patient is doing pretty good. I don't see any evidence of glaucoma based on that nerve fiber scan. As we look at that ganglion cell complex, again, very robust. I don't see any signs of that windshield washer type appearance, and they're both very symmetrical here in both eyes. So when I look at this, I don't necessarily see glaucoma at this point. Now, what are your thoughts, Dr. Epshtein? What do you think here? So this patient's pressures are 32, 31. She was told she had eye pressures before. She does have these larger CD ratios, but in the setting of a larger cup, a larger disc. And of course, our nerve fiber analysis looks pretty good.
Yeah, so based on the RNFL, based on GCA, I don't really see any definite signs of glaucoma. We got to look at the visual field testing, but the IOP is significantly elevated. She's been saying it's been going on since childhood. So if she's had 30 pressures, that's like really surprising. I don't think I've seen anyone that high have that
Sure.
high pressure for that long,
Right. Right. She's 51 years old now. Yeah, exactly. So just like you mentioned it, we've done a visual field. So this is the visual field here in the right eye. And as you can see, we did run the 24-2C protocols. Centrally, we do see a few spots. So it is one of the things that we have noticed here centrally. So let me pull my laser pointer here. So there you go. You can kind of see these central spots are flagged both on paracentral areas, but also those central points. As you mentioned earlier, the central points on the 24-2C, they don't replace your 10-2, but there's some high value points. So that if you do see defects related to glaucoma, the 24-2C will likely pick them up. If I do see points on the 24-2C centrally, my next step is to run a 10-2. So I think it is worthwhile to run a 10-2. But as you can see here, we do see a few defects that I think are suspect. I think it's worthwhile to have a look at. The other eye, on the other hand, actually, as you can see, look pretty good for the most part. So it is one of those things where I don't see that defect, or at least a significant defect on that side. In a case like this, I think the big thing that I was kind of leaving out here, or you might have picked up on it earlier, is this patient's on Tobradex. So Tobradex, there's a steroid in it. So my next steps on this particular patient is I want to see what this patient is or what their IOPs are after stopping that Tobradex. And that's exactly what we did in this case. What I didn't mention is that because this patient was taking Tobradex for the past 6 months, these little central spots, I actually relate that to the patient does have a very early cataract in that eye, a PSC cataract, actually in both eyes, but more so on the right-hand side as compared to the left. And I think that this could be what this defect is, but, as you mentioned before, anytime you see a defect, you have to repeat the test. I think it's worthwhile for us to repeat that test to ensure that it's just not an error in this patient taking the test. This is a relatively new test for a patient. I don't know her last 3-year glaucoma workup that she had in the US, if they've did a visual field like this on her, but I think it's worthwhile to repeat that test to see, is this a learning curve in the right eye where she finally picked it up in the left? Or is this related to a cataract? Or is this related to something else? So I think that a big lesson for this particular patient was the fact that, this patient is coming to us with a history of high eye pressures, but what fogs up that data is that your patient now has potential steroid response by taking Tobradex for 6 months. And now we do see some PSC cataracts worse on that right-hand side as compared to the left. That can skew your data a little bit. In a case like this, and this is maybe my opinion, and you can kind of chime in here as well, some ODs, when they see patients that in their office, their eye pressures are in the 30s, they want to treat this patient right away. But as we mentioned before, we really want to get a patient's baseline pressure. And if this patient's pressure has been 30 for a number of years, an extra week of having an eye pressure of 30 is not going to kill them. So it might be worthwhile for us to, repeat some testing, delve in a little deeper. And in this case, having the patient stop her steroid medication and re-baseline her. Some of my patients that I find, it actually can take weeks, 3 weeks, 4 weeks, sometimes 6 to 8 weeks for their pressure to come back down after they've been on a steroid for quite some time. I don't know what your experience is, Dr. Epshtein. What do you think?
The first thing is definitely stop the Tobradex.
Yeah.
I'd have the patient come back probably, a month,
yeah.
maybe 3 to 4 weeks, repeat the
Yep.
visual field, check the IOP again. Just because if you have the patient come back in a week, and let's say the pressure is 25,
Right.
you don't know, is that her natural pressure or is the
Exactly.
pressure still coming down? If you give
Right.
it 3 to 4 weeks, you're pretty confident that most of that steroid response, again, if there is a steroid response, has sort of disappeared by that point. So I'd feel a lot more comfortable with my IOP measurements at that visit. 31 is pretty high, and I wonder what the stats are on having 30, 31 pressure in a normal patient. I think that's like infinitely small probably. But in this case, she might have had high pressures in childhood, but that might have been 22.
Right.
That not necessarily means 30. So I think maybe with the history, sometimes you can sort of throw a curveball at you. So it's a very interesting case.
Exactly. This is why it's the bonus case. Yeah, that's exactly it. So it is one of those things where I definitely feel that skews that data. I think it's worthwhile for us to stop the medication. I did the same thing. I had her come back in 3 to 4 weeks. And unfortunately, due to COVID, she hasn't been back in the office. So I'm curious to know what the eye pressures are. And then what I would likely do is, you're absolutely right. Even if the eye pressure is 25, I may see the patient back in another couple of weeks to see if that pressure comes down. And then I have at least a couple IOP readings so I can reestablish her baseline. And that will give me a better idea of what her true risk is. But yeah, it's a fun case.
Yeah, I agree. Because from a glaucoma standpoint, this patient's either glaucoma suspect or worst case scenario, an early mild glaucoma case.
Right.
A few more weeks of high pressure is not going to do anything. The
Right.
only caveat is, the higher the pressure, the higher your risk for any type of occlusion within the eye. So, artery occlusion or venous occlusion.
Sure.
That's the only thing I would be worried about.
Yep.
The patient's 51's on the younger side, so probably not a vascular path. Stop the Tobradex, check the IOP in 3 to 4 weeks. I think you brought up a lot of great points, and there's a lot of information to really dissect with all our glaucoma patients and glaucoma suspect patients. So I think the big thing is having that practical approach to a glaucoma suspect. We talked a lot about glaucoma suspects, and of course we had to talk a little bit about glaucoma because they sort of go hand in hand. And I think a lot of the points that you want to keep in your mind is one, that sort of workflow we were talking about. So the big thing is to get your full glaucoma workup quickly. You don't want to lose your patients to follow-up. Sometimes psychologically, if you tell a patient to come back in 6 months, it sort of seems like, oh, it's not a big deal, and they might not come back until their yearly follow-up. So I like to see them back pretty soon within that 6-week follow-up. And again, like we talked about, until you have the data, until you have that follow-up, you don't know, is the patient low risk or high risk. So you really need to have all your information. Always take a step back and make sure you're dealing with glaucoma and not another optic neuropathy like we had with the bitemporal hemianopsia patient. And of course, you determine glaucoma risk based on testing. So you need your OCT of the nerve and the macula. You need your visual field, gonio, PAX, IOP. Of course, you're always looking at the optic nerve head. Age is important, and family history is going to be important for some of our patients as well. I think it's very important to get multiple visual fields. There's just an inherent variability in visual fields. Patients a lot of times don't like doing visual fields, but I always explain to them just how important it is that we have to repeat it. So up until they get through that learning curve, you might not have such good data. So keep repeating it.
Yeah, I think we've talked about this just the other day, in terms of, some of the reports from Quigley or another paper from Weinreb, both of those docs, they do like to get, within the first 18 months, they do like to get at least 4 or 5 visual fields. So I think that within that first 18 months or the first 24 months, so the first 1.5 to 2 years, I think it's actually worthwhile to get at least 4 to 5 visual fields. The other thing, I don't know what your thoughts are on this, is that, sometimes what I tend to do is I may switch my testing protocol so that I may, tend to do something like a 24-2C early or CETA, faster, just so they get maybe a feel for clicking the button. And then if I need, to dive in a little more, if I need more robust data, then I do switch back to either CETA fast or a CETA standard. So, it depends. In most cases, I do tend to do CETA standards, but, you kind of gauge your patient.
For me, I actually use CETA faster a lot. Since having the new upgrade to the Humphrey visual field, I've been using CETA faster and 24-2C in all my patients. So sort of the standard protocol.
Yeah, I think
I haven't found that there's more variability. I haven't found that it's significantly different than my previous 24-2 fast or standard patients, at least for now. Again, I don't have 10, 30 years of data on it, but maybe for the 6 months that I've been working through, it's been pretty similar. So I've been sticking with that. And it lets me just do more visual fields on my patients. So I think I might take a hit on the CETA standard versus CETA fast variability. So you have a little bit more variability, but I'll have more visual fields done in general. So I'll take the hit in one way to just have a bigger quantity of visual fields in general.
Yeah. And I think that's one of the papers from Crab where he looked at comparing CETA fast as compared to CETA standard. And if you have more visual fields, that variability decreases, and the difference between a CETA fast or CETA standard, you kind of lose that difference, so that a CETA fast is just as good as long as you have good longitudinal data.
With our glaucoma patients, our glaucoma suspects, we're not doing just snapshots. We're following these patients for years at a time. So at some point, quantity really takes over in these patients. You never want to miss these fast progressors. That's another reason to do a lot of visual fields in the first 2 years, because it's about 4%, maybe 5% of patients, they progress very quickly, so more than 1 decibel per year. And like we spoke about, 1 decibel per year, in 10 years, you go from no visual field defects to pretty significant loss, which can start affecting your quality of vision. The big thing is, of course, use this data to determine your follow-up and your need for treatment based on risk. Get multiple IOP readings before starting treatment. Ideally, I'd like to get 3. Sometimes if you have a patient with definite glaucoma, 30 pressures on 2 visits, I'm probably going to start treatment on that 2nd visit. I'm not going to wait for a 3rd visit. But if someone has more borderline pressures, very early glaucoma, I'll usually wait for a 3rd IOP just to get that for the patient, so I have a better idea of what their Tmax and just average IOP is. The way I explain it to my patients is that in the beginning, we're going to become very good friends. We're going to see each other very often, but as things become more stable, we don't see each other that often. So I have patients that I was seeing every 2 months, and then that goes to every 3 months, to every 4 months, and very few of my patients, I see them every 6 months, the glaucoma patients at least. I have plenty of glaucoma suspects where I see them 3 times in 3 months, and then I see them once a year after that. And I think as long as they understand that this is maybe just from the beginning until things get more stabilized, that they're more willing to come in for the follow-ups. And a lot of that's based on when you're grading your disease severity, that's going to determine your follow-up and determine your target IOP. Of course, you have to repeat your testing, you have to check for progression, and I think the Zeiss guided progression analysis, or the GPA, really makes it very easy, because as you showed with your case, sometimes when you eyeball the RNFL or the visual field, you might not have the best idea of is it true progression, or is it variability? Is it a patient that's variable? Is it a machine that's variable? Is it age-related change? But the GPA really takes all that into account, and it gives us an objective measure of progression. So instead of having 10 different docs look at the same data and give you 10 different opinions, you have one objective data point on progression. And like you said, progression is the key to glaucoma. Without progression, probably not glaucoma, or you've treated it very, very well.
All great points. Glaucoma is not a cookie cutter approach, but the tools, of course, of visual fields and OCTs are really essential in judging risk and managing our glaucoma patients. You'd be hard pressed to find, a glaucoma specialist who doesn't, have an OCT or use visual fields and such. So, having the data is so helpful. It's so important.
If you really have a systematic approach to how you think about these patients, it really makes it much easier. It doesn't stress you out as much during your day-to-day. And with that, thank you all for being here with us. Thank you, Zeiss. Thank you, Covalent Careers. And we have to thank Hanayo. She's behind the scenes, really doing a lot of heavy lifting. If you have any questions, this is my email and Dr. Laul's email. We're always open to talk shop. If you want to talk about any cases here, about glaucoma or anything imaging in general, feel free to send us an email. And we'll be here for answering some questions as well.
Well, that was a fantastic overview with a lot of great cases. Glaucoma is definitely one of the more challenging conditions to really just get comfortable treating. I think no matter where you're at in your stage in your career, we're going to continue the conversations here. I'm going to give our producer here a moment to bring in Drs. Epshtein and Laul. So once they join me here, we'll pick up the conversation. And looks like all 3 of us are in and together. So thanks again for sharing those cases. That was a really great presentation. We wanted to use this opportunity to take a lot of questions that came in while you guys are presenting. So I've been watching. I'm going to take it from the top, and we'll kick it off with the first question here. So, and this question had come in early on in the presentation when you were showing the map, sort of your protocol. but so a couple of these questions were, when you're suspecting glaucoma, do you do only fundus photo at the first visit and then do additional testing at follow-up visits? So Dan, I don't know if you want to speak to that. I believe that was your specific slide when you were presenting that.
Yeah, sure. So for me, what I end up always doing is the fundus photo on the initial visit along with the dilation, but that's just because of the workflow of my clinic. Every clinic, every office can run a little bit differently. So especially if you're thinking maybe patients might not come back, they might be lost to follow-up, maybe you want to also include chemistry or corneal hysteresis in your first visit. But usually I like to just sort of do everything on the back end where I load it onto that second visit. Anu, how do you usually do it? I know your clinic runs a little bit different.
Correct. I usually do my OCTs, visual fields, PACS, and gonio on my first visit, and then I have them back in depending on what the results are of that visit, and then that's when I usually dilate and take fundus photos. So it could be anywhere from a month out to maybe 2 or 3 months out, but again depending on the risk.
Great. We'll keep running on the same topic here, but question came in. Why do you only obtain a repeat OCT for the low-risk patients and not for higher-risk ones?
So maybe that's something that I didn't make clear or I misspoke, but the OCT, I get it once a year on every single patient. On some patients where I'm really worried about fast progression, I might do an OCT every 6 months. So it's not just low risk, it's low risk, medium risk, and high risk patients that I'm doing OCT at least once a year. Visual field also, it's going to be at least once a year in those patients.
Great.
Sure, and I think sort of one of the things to consider as well is that once the patient does have glaucoma, then your does change a little bit, and of course the usefulness of the OCT in very severe glaucoma cases, the visual field tends to be a little bit more useful.
Yeah, and another question here that came in was, would you recommend having all new patients on their initial visits to undergo tests in case they become glaucomatous? And do you have data to reference this, if so?
So I think that's a really big topic going on in not just the glaucoma world, but just ocular disease in general. Our imaging has gotten so good nowadays that should we be doing imaging on every, let's say, 40-year-old or 45 plus every single year to see if anything's changing? So there's actually a really big glaucoma specialist in New York City who recommends that ideally we would do it on, I think, everybody 45 and over every year. I think as our data management gets better and patients can sort of have some sort of own access to their OCTs and their visual fields, their glaucoma information, we're going to be more likely to do all this testing maybe a little bit earlier. But then again, the question comes up of, are you going to get paid for it? Well, the question is also going to be, is it going to be something that you do for the patient's health or something just for billing purposes? That's going to be a tough question for insurance companies to answer. But as far as actual evidence, I don't know if there's anything to say that we should be, doing sort of like a shotgun approach on all the patients that we see.
Yeah, and I think it also depends on your demographic of your patients and such. Because in all honesty, I mean, think about your 20-year-old, myopes that you tend to see, your -1s or whatever it may be. If you have an OCT or a visual field on every single one of those patients, and unfortunately, I mean, you're really not going to be catching a lot. So it is, again, I don't know if there are studies out there. I know some of the companies are looking in versions of their OCT technology or the technology, and that's a possibility. However, I don't think there's data out there at this point.
Yeah, these are all fantastic questions, and there's a handful more here, so we'll keep going through them. And very interesting question here. Do you recommend using gold mount tonometer and gonioscopy considering the current COVID situation?
So for me, yes, the gold mount is the gold standard of tonometry, and gonioscopy is the gold standard of evaluating the angle in our glaucoma patients. I think we might be a little scared, but I just went to my dentist, and I had a cleaning done. So for 20 minutes, my mouth is open. And he's right in my face. So if the risk isn't that high for them, where my mouth is completely open and might be aerosols coming out, things like that, if they're okay with that, I think we should really be okay with doing gonioscopy and tonometry, especially if we have, I know Zeiss gave out breast shields. I have them in my office. We're using goggles for all our providers as well. So I feel pretty safe. And, like today I had maybe 15 patients, about 7 of them had gonioscopy and all of them had tonometry. So I'm feeling pretty safe, definitely.
Yeah, totally agree. As one of my hats at the college is the chair of the infection control committee, and we set up protocols on proper cleaning of each of those devices, so the Goldman and the gonio prisms. If there is some concern, there are disposable prisms and there's disposable gonio lenses as well. However, as long as you clean appropriately, I think you'll be in good shape.
Yeah, fantastic question. And the next couple of questions here are in reference to one of the cases. So for the disc heme patient, why is he a definite glaucoma patient? I'm not seeing the correlating RNFL OCT thinning in the right eye. So let's start with that question first, and it looks like there are a couple of follow-up questions, but let's start with that one.
So for me, that patient's a definite glaucoma patient because that disc heme actually did correlate to RNFL dropout, especially when we looked at the deviation map. There was that little sort of slit defect that correlated inferior temporal, and that to me is definite RNFL OCT dropout.
Got it. And another question here, maybe more general, when comparing RNFL quadrants, what difference will make you more of a suspect of glaucoma?
Yeah, so me and Anu were actually just talking about this, and I don't know if there's any good evidence for the actual quadrants, but if you look at the average RNFL, the disparity between the two eyes, if you have a difference about 8-9 microns in the average RNFL, so that's 360, that should give you some suspicion. With the quadrants, it's a little bit tougher because there's more variability in quadrants than there are in the average RNFL. Because as we know, the blood vessels will affect your T-SNP curve, which affects those quadrant analyses. So then, of course, if you just have slightly different nerves, so if you have one that's a little more tilted or one that's a little bit larger or smaller. So for quadrants, it's a little bit tougher, but that's something that I look for on all my patients, which will help me correlate to anything I might see on the visual field or anything I might see clinically.
Mm-hmm. And I think the real benefit, of course, is also progression. So because of the fact that our quadrants big range, especially superior and inferior, so a huge range in terms of thickness. So that being said, unfortunately, picking out a tiny sort of defect based on just quadrant thickness alone is a little difficult. And I think that's where the value of looking at change over time is. So if you're unsure, just have the patient back and repeat some of the testing.
Some more questions here. I'll keep passing them along. And this might have been maybe in reference to a case or just looking at it, I think perhaps it can be even more general. Would you initiate treatment OU or just OD, assuming your first line is a prostaglandin? And I think this question here was piggybacking perhaps off of that previous OCT question where, maybe you think that one eye is glaucomatous and the other isn't, but perhaps you can speak on this just as a general rule of thumb.
So if we're talking about primary open-angle glaucoma, I'm almost always going to initiate treatment in both eyes because we know primary open-angle glaucoma is a bilateral but often asymmetric disease. The patient with a disc heme, yes, there's definitely glaucoma in the right eye. The left eye didn't really show anything. But in that patient, I initiated treatment in both eyes because we know that the left eye most likely would follow along with the right eye. The only exceptions to the rule is if a patient, for example, has some sort of significant asymmetry. Like I've had patients that have maybe plano in one eye and then a -20 diopter eye in the left eye. And there you can clearly tell that the eyes are very different. So it's hard to look for symmetry or asymmetry in those types of eyes. So I might maybe only initiate treatment in one eye, but that's really going to be the exception in POAG. If you have angle recession glaucoma, like today I had a patient comes in with unilateral glaucoma, 29 pressure in one eye, the other one is 15, angle recession, a history of orbital floor fracture. That's a glaucoma that I'm going to treat unilaterally, at least in the beginning. A lot of these angle recession patients, they tend to develop glaucoma in the other eye, but maybe in like a decade or two later on.
Yeah, I totally agree. I think with your secondary glaucomas, you need to kind of play that by ear. Just like you said, glaucoma is a primary open angle glaucoma is a bilateral condition.
Right. Some questions here around visual field testing. So I'll try to lump these all together because I think many of them piggyback off of each other here. But when do you incorporate 24-2 CETA FAST into baseline testing? And can you reiterate what the new protocol is for visual field, which adds 10 more central points, I suppose, talking about 24-2C CETA faster?
So I think the choice is going to be clinician specific. Personally, I'm doing CETA faster, 24-2C on all my patients right now. I'm not really seeing much of a difference when I compare it to my previous visual fields, which were CETA fast, 24-2. If we're going to look at the research, we know that 24-2 CETA fast is going to be a little more variable and a little less sensitive than CETA standard, but it's much quicker. CETA faster is about the same as CETA fast. So to me, they're pretty interchangeable in terms of repeatability, sensitivity, but we know it's also a newer protocol, so I think we're all still sort of trying to get the hang of it. I think you're doing CETA standard for most of your patients, right?
Correct. Yeah. So essentially, in terms of the data itself, if you only had one test, you can only do one visual field, the CETA standard double checks a lot of those points over and over again. And that's why it takes a little bit longer, as opposed to the CETA fast, where based on what it tested already, it makes assumptions. And that's why it can do that same protocol at half the time. However, as a study that I mentioned in the lecture from Crab, if you have many visual fields over time, all these variabilities do tend to even themselves out. So that being said, if you're running 5, 6, 10 visual fields on a patient, then it really doesn't matter if you decided to do one of those faster protocols, you're still going to get very good data.
Great insight.
I don't know, Dan,
fantastic.
If you want to talk about the 24-2C.
Oh, yeah. So 24-2C, what that is, it's the standard 24-2, but then it has these 10 central points. And those central points there, it's an asymmetric pattern. And the reason why it's asymmetric is because a lot of our data on macular glaucoma defects from Don Hood and his laboratory shows us that the defects on both the RNFL thinning and the visual field are going to be asymmetric just because the retina is wired that way. So we know the fovea doesn't sit right at the center of the optic nerve. It sits sort of on the bottom edge of it. So due to that asymmetry, our defects are going to be asymmetric. So that's why they chose that specific pattern.
I wish I had both of you guys on demand when I was seeing a bunch of patients with glaucoma. That would have been super helpful. But, a couple other questions here that came in, and one's around narrow angles and imaging. And I know, Dan, that you have definitely, I know I've seen some pictures that you have sent me with OCT imaging of the angle, but I know you also have told me before that it's not necessarily a replacement for gonioscopy, but certainly nice to complement it. So any thoughts from you, Dan, or you, Anu?
Yeah, so I definitely use it in my practice. What I like to use it for is, number one, of course, patients that can't sit for gonioscopy, patients who have tremors, patients who have issues with their neck or their back, which unfortunately I have quite a bit. So sometimes it's easier to just get an OCT image for them. But the other thing I really like is now we're getting more and more information. There's a lot of other parameters. So not just looking at what structures you can see. With the anterior segment OCT, you can see how the iris and the lens sort of sit together. You can see that complex. You can see how the iris is going to drape not only over the lens in the center, but also peripherally. Things like plateau iris, you can tell. And we also do have some form of objective measurements with the OCT, whereas with gonioscopy, depending on how hard you press on the eye, how much light you use, depending on how pigmented the angle, it's pretty subjective. So it's a little bit tough. But now that we're getting more and more research with anterior segment OCT, I think it's going to start becoming a bigger part of our glaucoma workup.
I mean, I definitely use both. So obviously the advantage of the gonio lens is that you can look at pigment. You can't see how much pigment's in the trabecular mesh with an OCT. When it comes to things like PAS, things like areas of recession, I mean, these things you can only get using a gonio lens. However, one big benefit of the OCT is that obviously it's quick and it's very easy for the patient. The other thing that is that you could be the best person in gonio, but you are still putting a little pressure on the eye, which you could make the angle a little bit larger. Now, sometimes you want to do that, so it is indentation is absolutely necessary, on your patients who do have this plateau iris appearance. But sometimes, if you want to see a more natural looking angle, that's where the OCT comes in handy. The other thing is, as Dan mentioned, is that you can do it in the dark, so you can actually see what things look like in a completely dark room, and then the other sort of big benefit there as well is that you're not using any light, you're not making that pupil any larger. So yeah, I think it's a great objective measure.
Yeah, I remember gonioscopy definitely being one of the most challenging skills to learn. At least I had the most trouble learning this in school, just trying to, especially three-mirror, getting that three-mirror on a classmate's eyes. I can't tell you how many corneas I ruined during those times for sure. But other than just practice, question came in here just about any tips or tricks on maybe how to do a gonioscopy on someone who is maybe a bit more sensitive or has a bit more of a reflex or reaction, so to speak.
Maybe 2 drops of proparacaine instead of 1. I think the real trick is making sure that you're holding the lids. That's a lot of times what patients feel. They feel their lids on the lens, and that's when they sort of freak out. And the other thing is you have to get good at gonioscopy because then you're quicker and the patients can be less uncomfortable. A big thing that I would teach the students back when I was an adjunct was always have your elbow resting on something. You can use the lens case or pick something like the edge of the slit lamp. This way your hand is steady and you'll get a much better view, and it'll be just a quicker sort of exercise overall.
Mm-hmm. The other thing is, you could consider, using some Celluvisc or some, thicker artificial tear. And in some folks, the flange is helpful because it keeps that lid back. But practice is actually the best thing. So just keep on doing it, and you're going to get really good at it.
Yeah, we'll definitely one of those things that improves with practice for sure. So really just time for one last question here, and I'll try to lump these together because there's a couple here around GPA analysis. So I'll throw them at you guys here, and we can wrap it up. But how many data points are needed for GPA analysis? And a piggyback question, will the GPA continue to work the same if you switch between, the protocols?
So
it's very, very good question.
Yeah, go ahead, Anu. You can take this one.
Oh, sure, yeah. So in terms of how many, for a visual field, you need a minimum of 5. So 5 visual fields for a GPA analysis. You can also get a GPA analysis on the OCT, you need a minimum of 3. Your question on if you're switching protocols in Zeiss Forum, now what you can actually do is you can choose if you wanted a 20-2 standard versus a 24-2 fast, or what I usually do is I put it on mixed. So what that does is that it includes every single visual field that I've done into that GPA analysis. So you do have the ability, if you are switching protocols, to actually take advantage of the GPA.
Yeah, I think that's something great that Zeiss did, that even though the 24-2 faster and 24-2C are different, they're still adding the GPA. So I'm still doing GPA on all my patients who have 10 years of 24-2 C to faster data. And, you know, the forum makes it just much easier because you can look at years and years of data just very, very easily.
Great. Well, Dan and Anu, thank you. And I'm echoing everyone else here in the chat who's also saying thank you. So thank you for your time and sharing your cases and answering all these questions. Really appreciate it. There's I think a couple more that might have come in, but we'll put your email addresses in the chat for those that want to reach out to you. We'll take those from that last slide that you showed us all, Dan. So thanks again. Really appreciate it. Have a good rest of your night.
Thank you. Thanks for having us.